And again, I'm Dr. Raymond Anders. I'm at University Hospital's Cleveland Medical Center. And so it's a great to have all of you here to listen to some of our experiences in diaphragm pacing. This technology has been around for 20 years. It was developed at Case Western Reserve University, and I've been doing it for many years, but it's wonderful to have other people to share their experiences and what they've been doing. Dr. Andy Kerwin, I think I've known for, geez, almost 15 years ago, and he's going to share his experience and some of the articles he's published about. He actually did his trauma training in Memphis, and that's where he's back now after over 20 years ago, and he did his trauma training well over 20 years ago. He spent almost 20 years as a trauma surgeon in University of Florida in Jacksonville. And just this year, he actually went up to Memphis where he did his fellowship training at, become their kind of the division chief of trauma and surgical critical care. And so again, at the end of this, we're going to have time for questions, comments. You can also put it in the chat, and I'll try to keep track of those and go over it later. But for those people that are here already, we're going to have Andy Kerwin start discussing everything in his experience and kind of talk about diaphragm pacing and what we've learned over the last 20 years of doing this and what he's had great experience with and using. So with that, I'll turn it over to Dr. Kerwin, and it's a pleasure to hear him talk and give his experience. And I love his background of Memphis at night on his screen there. So again, Andy, thanks for helping out and sharing your experience with diaphragm pacing. So you can take over the screen and share it.
Okay, I'm going to share, and I think it'll I think it'll work. Let's see. I can minimize that. Everybody should see my screen.
Yes, it looks great. Thanks.
Okay, great. Yeah, so thanks, Ray. I appreciate the opportunity to talk and share my experiences. As Ray said, I spent just shy of 20 years at the University of Florida in Jacksonville, and this was a key opportunity to take over in a leadership position at a trauma program with a long legacy of excellence and a long legacy of patient care and research contributions that were important to not only care in Memphis, but really throughout the whole world. So it was really a very unique and cool opportunity for me professionally to take over and be the lead here in Memphis. So, but my experience will be based on work that I did in Jacksonville when I was chief of trauma in Jacksonville. So let's see. All right. So I have nothing to disclose financially today about this talk. I won't talk about any non-FDA approved procedures either. So, okay, so I just want to spend a little bit of time talking about the changes in respiratory function that occur after a cervical spinal cord injury, a little bit about the consequences of mechanical ventilation in patients who have a cervical spinal cord injury, and then I'll share with you my experience over about the last 10 years in Jacksonville using diaphragm pacing in the management of acute cervical spinal cord injury patients. So this is a nice table that shows on the left side of the screen, shows all of the nerve roots involved in respiration. And if you look on the right, you'll see the problems, the changes that occur in a patient who has an acute cervical spinal cord injury, and the things that plague us as trauma surgeon intensivists that really hamper the patient's ability to get off of a ventilator and get out of the ICU. So it's reduced vital capacity. The chest wall gets stiff and has reduced compliance. The lungs have reduced compliance, and these are really the biggies that cause a problem for the patients. The impaired cough, the weak cough, and the inability to clear the increased secretions that the patients have, and it results in prolonged ventilator stays. It results in mucus plugging, pneumonias, a need for bronchoscopy that can be an immediately life-saving intervention. Someone who has lobar atelectasis and can't clear their secretions. A little smattering of papers here. Oops, sorry, clicked ahead. That talks about the impact of positive pressure ventilation and what happens to the diaphragm during mechanical ventilation. And I highlighted there in orange the things that we see: inefficient ventilation and muscle fatigue, and then that's most severe in acute cervical spinal cord injury. Within the first 18 hours, marked atrophy of the diaphragm, which is shown here in this New England Journal article. The muscle fibers, and you can see how they begin to atrophy in size just after a short stay on mechanical ventilation. These are biopsies of the diaphragm. And so with that atrophy and muscle fatigue, there's also a decline in the diaphragmatic force. So that really hampers our cervical spinal cord patients and their ability to have a good ICU course without prolonged mechanical ventilation. We've all seen this X-ray here on the left, this whited out the left lung from lobar atelectasis, and you stick a bronchoscope down and you'll see at the carina, you'll see these thick white mucoid secretions just plugging up the left mainstem bronchial orifice, causing that picture, and it requires emergent bronchoscopy to clear those secretions and clear that lobar atelectasis. And many times in my experience, it was repeated episodes of bronchoscopy. We would stick the bronchoscope down, clear out this thick mucoid secretions here, but there was still a whole bunch more that was distal, and it would take time to get the lungs to be better aerated, and repeated bronchoscopy to try and clear those secretions out and aerate that lung better. And then obviously it could lead to ventilator-associated pneumonia, which complicates the course even further. Many of these patients require tracheostomy to facilitate liberation from the ventilator. This is the Denver experience over 15 years. Looking at on the left side is patients with complete cervical spinal cord injuries and the likelihood of needing a tracheostomy. And you see, even for the low injuries, and this is where I think a lot of people get have a false sense of security as well. It's below C5, and so the patients should be able to wean from the ventilator and not need a tracheostomy. But this Denver experience over 15 years, you'll see that even those C6 and C7, almost 80% of them required tracheostomy. The higher injuries that approaches 100%. On the right is the incomplete spinal cord injury patients requiring tracheostomy, and so you'll see it's not near as much as the complete cervical spinal cord injury patients, but still a lot of those patients need tracheostomy for prolonged mechanical ventilation. And then that was my experience in Jacksonville as well. I found that when we went back and looked over a long time, that a lot of almost all the complete cervical spinal cord injury patients did require tracheostomy because of need for prolonged mechanical ventilation. And it was about half of the incomplete cervical spinal cord patients that needed tracheostomy for prolonged mechanical ventilation. It's a difficult problem, not only acutely, but also chronically for these patients, as 20% of them end up in a rehab facility that can provide mechanical ventilation and continued ventilator weaning to facilitate liberation from the ventilator. And this was what really piqued our interest when I worked in Florida. Someone in the Florida Committee on Trauma got interested in the work that Ray had been doing in Cleveland with diaphragm pacing for chronic vent-dependent patients, and brought Ray down to us probably about 2007 or so, and said he gave a presentation talking about his use of diaphragm pacing in chronically ventilator dependent patients. And that's where it piqued my interest, and I'll comment on that in a minute. So it's a terribly costly injury, as you can see here on this slide. Just in the first year of medical care, okay, for a high spinal cord injury above C4, over $1 million in the first year of care, and then almost $200,000 in each subsequent year, $800,000 for the C5 and lower injuries to get through the first year, and just over $100,000 for the each subsequent year. So a lot of cost and complications with it. It does also, the tetraplegia does also have an impact on long-term survival. This is an English study looking at the experience with patients with acute cervical spinal cord injuries and whether or not they required mechanical ventilation. And you can see that these are young, healthy patients in the prime of their life. But you can see that if you were dependent on mechanical ventilation following your injury, your long-term survival was essentially cut in half. And so, again, a very complex injury that's really devastating, with not only immediate life-threatening problems, but also with long-term impact on survival for patients. So it's a terrible injury, and it piqued my interest. And I said, well, when Ray came down and talked about it to the Florida Committee on Trauma, what could we do about chronic vent dependence, and got us interested in Florida. This is a review from England. Talks about saying that diaphragm pacing for high cervical spinal cord injury is safe, effective, and I like this last bullet point here. I think that's important, and that's what piqued my interest as I learned about this from Ray, and I thought, well, what could we do rather than approaching this and someone who's chronically ventilator dependent following their injury? What if we approached it acutely? What could we do to try and prevent that chronic ventilator dependence? And then I started asking, and I think maybe I even asked Ray when he was there in Florida talking, well, why couldn't we just do this early on rather than have the patient with that prolonged ICU stay, multiple bronchoscopies, probably a pneumonia, probably a 6-week stay in the ICU, longer transition to rehab. And so I started asking that, and Ray's was one of the papers Ray's written looking at chronic vent dependence, and you'll see the average time to implant about 4 years. Almost 2/3 of the patients get liberated. And this little graph here, it's maybe a little small on the screen, but it shows the change in spontaneous tidal volumes of patients experienced after implantation of the diaphragm pacing and conditioning of the diaphragm. And you'll see that it does go up after the use of it, and improves the mechanical ventilation and liberation there. And he commented on this paper that almost 3/4 of the patients liberated, if they were implanted within the first year following their injury, they were liberated from the ventilator. And then one of his conclusions, consider earlier implantation of diaphragm pacing. And so as I said, after I heard his first talk to the Florida Committee on Trauma, I said, well, why couldn't we do this or early on and prevent this long-term ventilator dependence and a need to be in a long-term ventilator unit, trying to be liberated from the ventilator or be on a ventilator at home. And so that piqued my research interest, which I have in a few slides to tell you about what I discovered in Jacksonville. So just transition a little bit to the surgical technique for these patients. And once I was able to get this program up and running in Jacksonville, Ray came down and proctored me, and it's a case done with diagnostic laparoscopy. Everyone's familiar with this setup. It's 4 trocars. I usually enter the abdomen with a Hassan trocar just above the umbilicus, and 2 5-millimeter trocars laterally below the costal margins, and then a 12-millimeter trocar in the subxiphoid region, which is we use for the implant tool that I'll show you here in just a second. You could, if you chose a different access way, it would be okay, I think, but really key to have that 12-millimeter trocar in the mid-epigastrium for the implant tool here, which I'll show you here. On the left is this big kind of scary looking tool, which has, when you close the handle on that, this needle pops out, which I think is about an 18 gauge needle, and it has threaded through this long tube here that you'll see. It has this small electrode threaded through there, and that's the electrode that gets implanted in the diaphragm. There's 2 implants in each diaphragm, one for the anterior aspect of the diaphragm, one for the posterior aspect of the diaphragm. And this is the tool that would go through the mid-epigastric port to implant implant those electrodes. I have a short little video. Hopefully it's going to work. This is going to show us the implantation of the electrode into the left diaphragm. You can see at the bottom is the left lobe of the liver. The spleen's tucked up under the omentum there, central tendon. And this vein here I usually used as a sort of a zone of area where we were going to map and stimulate the diaphragm and make sure that the diaphragm contracted. And so this is that tool coming in through the mid-epigastric port. The Maryland dissector there to grasp the wire, and as the implant tool was retracted out of the abdomen. And so I just kind of tent the diaphragm up with the tip of that needle. And as you know, the diaphragm is very thin muscle, and I just kind of thread that through there like that. Sometimes I'll use that Maryland dissector to put a little traction on the diaphragm as I try to thread that needle and that wire into the diaphragm, and then I just hold that wire in place as I retract the tool out of the abdomen. So that was an implant in the left side of the diaphragm. As I said, there's two implants on each side, one posteriorly and one anteriorly. And you'll kind of see, here's the right side, here's the right lobe of the liver. You'll see this little blue end of the electrode in the posterior aspect of the right diaphragm. And then this just shows you how we implant into the right side of the diaphragm. Again, this is coming in through the mid-epigastric port. You see we've divided the falciform ligament to get that out of the way. Just sort of engage the tip of the needle into the diaphragm. I'll try to grab that wire with the Maryland dissector so that I don't pull it out of the diaphragm as we're retracting the implant device out of the abdomen. And now you'll see there's 2 electrodes implanted in the right side of the diaphragm there. It's kind of what the picture would look like here. On the right, you'll see, I think this is actually from one of Ray's manuscripts, 2 electrodes implanted in the left side of the diaphragm. Again, there's the left lobe of the liver there, omentum, and the anterior electrode, posterior electrode. There's a lot of excess wire that's left inside of the abdomen to ensure we have enough to tunnel through the subcutaneous tissue and out to be able to connect to the external pulse generator. This was a clip I made of 2, you'll see 2 electrodes implanted in the right side of the diaphragm. Here's the right lobe of the liver, and then the 2 electrodes at this time are outside of the abdomen and connected to external pulse generator that's off the surgical field. And here's going to show you the full stimulation of that right diaphragm with a stimulus from there. And you can see it's a very vigorous, symmetric contraction of the diaphragm with the implant in place. And so that's that got my interest in this technology. And so this on the left is the external pulse generator, which is connected through this gray patient cable and connected. And you'll see the subxiphoid port would have the wires tunneled in the subcutaneous tissue underneath or just below. I usually bring them out just below the right costal margin. The reason for that is these patients, when I took care of them, I always put pegs in them. I thought, well, the patient can eat, but it's hard for them to eat because they don't have good motor function in their upper extremities to actually feed themselves. And so if they were not already pegged, I would do a peg at the conclusion of the implant of the pacing system to allow that feeding access and get the feeding tube out of their nose. And you can see the tracheostomy here. They're connected to, or not connected to any ventilator, and have a Passimier valve on there. And this pulse generator would then provide the impulse to generate that contraction. The pacer is programmed at the time of surgery based on the level of sensation. We would try to estimate that the best we could preoperatively, so that the impulse wasn't too intense and didn't produce any electrical tingling or shocking sensation in the shoulder or the neck. If they did that, then we would program this at the bedside and decrease the amplitude of the impulse and get it to a point where the patient could tolerate that that impulse, and then use the pacing system for conditioning of the diaphragm and clearance of secretions, liberation from the ventilator. Okay, so that was there. And so the pacing system is used for conditioning of the diaphragm. It one thing I kind of had to experience, learn about, and communicate to all my staff was, well, this isn't going to be a magic thing, and the patients aren't going to come off the ventilator immediately. It's going to help to strengthen that, or really prevent that atrophy that we talked about in the beginning, and try to strengthen the diaphragm and help with liberation. It is a technology only used with a spontaneous breathing mode. And if the patient, for whatever reason, if there's a decline in their condition, that requires them to be on a full support mode, then the pacer needs to be shut off, because as it won't sync with the ventilator. And so these are the goals that we're trying to accomplish with the patients, and restoring them back to volitional breathing without a ventilator, and improving their clearance of secretion, so they don't need bronchoscopies to clear out all their secretions. So anyways, after hearing Ray talk and learning about the technology, I had some questions, and that's what I was saying. I proposed, well, why wait for someone to be on the ventilator at home or in a facility for a year or longer? And could we implant early and prevent the pneumonia that keeps them on the ventilator? Could we get patients facilitated from mechanical ventilation? Could we improve mortality? And could we expedite transfer to rehab and try and get the patients reintegrated back to their family and back into the community, rather than spending 6 or 8 weeks in an ICU and then being so debilitated that they're not even ready to go to rehab? So those were my questions that I kind of started talking to people about and thinking about, and kind of how I approached this problem in Jacksonville. And so once we were able to get get the program up and running in Jacksonville. We did a few implants, and Ray was talking to other people around the country and said, well, why don't we use this acutely? And so we got a few at our center, and some others had a few. And I said, Ray, let's put it all together and see what it's starting to look like. And so we compiled some data from what we have 6 or 8 different centers around the country, and we had combined 29 patients that we had the institution had approached following an acute cervical spinal cord injury, and approached them for implantation of the diaphragm pacing system. So this was the first 22 implants, and you'll see now here this is a little different. Remember that Ray's paper talked about in the chronic patients it was almost 48 months to implant, and now we're here at 40 days implanting. And so you'll see that at laparoscopy, mapping out the diaphragm and finding a diaphragm that could be stimulated to contract like I showed. 3/4 of the patients had a diaphragm that could be stimulated, and they could have an implant. And you'll see almost 3/4 got weaned from the ventilator. Another 9% had some delayed weaning. A few ultimately had care withdrawn, and some patients had partial weaning. But here's the thing that really piqued our interest was 10 days average time to get free from the ventilator following diaphragm pacing implantation. And so that definitely piqued our interest in Jacksonville. We kept on approaching our patients with this. The one thing I would say about that is people ask, well, how do you screen for the patients? And initially we tried to identify a patient who would have a diaphragm that could be stimulated at the time of surgery, and the diaphragm that had not atrophied so much that the patient couldn't have the diaphragm stimulated. And we would do some sniffs tests to see if they were if the diaphragm moved with sniffing. I think Ray had written about use of phrenic nerve EMGs to see if the diaphragm could be stimulated. But we just as we kept doing it, we kept trying to do it earlier and earlier in the course, and just approach the patients as soon as their physiology was restored back to normal with their injuries the best we could, and as soon as their spine was stabilized, if they needed surgery to stabilize their spinal column fracture, we started just approaching them with laparoscopy and seeing if they could have their diaphragm stimulated. And we found as we did it early, every patient, unless they or their family asked about advanced directives and weaning from life supports and comfort measures only, we approached them for diaphragm pacing. And so as I started this, my first hypothesis was, well, let's implant these patients early on in their care, and let's try to facilitate being liberated from the ventilator and see if we could decrease ventilator-associated pneumonia. So this was the results from the first paper that we wrote and now published in the Journal of Trauma. And this was an IRB-approved study. You know, this was I went back for a long period of time. You can see there back to 2005, pulled all of our acute spinal cord injury patients, and then used the historical controls from prior to the time when we started the diaphragm pacing implantation program, which was in July of 2011 when Ray came down. We implanted 2 patients, and we matched the patients really well based on the things you see there, and then looked at those outcome measures to see. Again, my hypothesis was, well, I could decrease their vent days and decrease the ventilator-associated pneumonia and decrease mortality. And so during that study period, 649 cervical spinal cord injury patients, these were the first 40 patients that we did in Jacksonville that got an implant, and out of the remaining 609, I identified 61 patients that were matched based on those conditions, and those were my two study groups that we've used for this study and the other two that I'll talk about in a minute. And so this was just looking at the markers of injury severity, and so you can see both groups are really severe injury patients with high ISS, some element of shock there, as you see some hypotension and tachycardia. The GCS is the same. AS for the chest and face is the same for the two groups. No difference there. And so you see that these two groups are really well matched for injury severity when we compared them. And you'll look at the spinal cord injury characteristics of this group, and so you'll see that about 2/3 are lower injuries, C5 to C7, and about 90% are complete cervical spinal cord injuries. Similar demographics in the non-DPS patient group. And so it's, as you can see, it's a difficult injury to manage. So with our first look at the statistics, I got really excited. These were just unadjusted outcomes, and I saw that, well, boy, only one patient in the DPS group died, as opposed to 9 in the no DPS group. So there was some significance to that. There was some significance in the length of stay, but these were the unadjusted outcomes. And then my hypothesis about ventilator-associated pneumonia, I was disappointed. I couldn't show a difference there in the ventilator-associated pneumonia. What I did notice, though, is almost 40% of those patients that end up having a pneumonia diagnosed during their stay occurred within 3 days of the implant of the diaphragm pacing system, which kind of led me to believe that process was already underway, and they already had their pneumonia at the time of implantation. So that was our first study, and so we said, okay, I couldn't prove my hypothesis that I could decrease ventilator-associated pneumonia, but I could at least show it was safe and it was feasible. The study, as I pointed out in the beginning, was over a long period of time, almost 15 years, and there are no doubt some definite improvements in critical care during that time, which may have skewed our results. But I said, okay, well, let's keep working. Let's keep looking at this and seeing if there's really benefit there. And so on that same study group, my next cut of the data looked at, well, how did we improve the respiratory mechanics in those patients? And I was able to pull from the records the spontaneous tidal volumes that were documented by the respiratory therapist in the charts, and I wanted to see, well, if we're going to stimulate the diaphragm and make it contract more vigorously, help clear secretions, my theory was there must be some improvement in the respiratory mechanics, and I measured that through the documented spontaneous tidal volumes, and this was our second paper that was published last year in the Journal of Trauma about that. So same study group that I mentioned for the first study, just a different look at it. And so what I did for the patients that did not get a diaphragm pacer system implanted, the historical controls, I looked at the initial spontaneous tidal volume that would be recorded by a respiratory therapist around the time of admission, right? I put day 0, but I didn't get the very first one that was recorded, say, on admission. I made sure that the patient was stabilized and they were having spontaneous efforts in that first day or so. And I recorded that. And then I looked at the spontaneous tidal volume recorded at day 14. And the reason I chose that was from our first paper that I had written and mentioned there. The average time to implantation was at day 14. And so that's why I picked that day of comparison. And then what I did for the DPS group, those that got implanted, I went back and I looked at the best spontaneous tidal volume that was recorded in the chart, 72 hours before the implant, and then 72 hours after the implant. And this was really exciting to see, and I have it in the table here. So the left side here is the 40 patients who had diaphragm pacing, and you'll see this was really key. 88 milliliter increase in tidal volume on average, and compared to the no diaphragm pacing group, the tidal volume went down by an average of 13 milliliters. So about 100 milliliter difference. And you say, well, that doesn't sound that exciting, but if you think about it, you're just the tidal volumes are not big to begin with, or depending on the size of the patient, 6 milliliters per kilo, so you might have 350 milliliters for 450 milliliter tidal volumes. And so if instead of a decline over the first 2 weeks in that tidal volume, we can actually increase it, well, then heck, we could do better, clear those secretions. And we showed in this, when we did the multivariate analysis in this group, or in this study, we showed that we were able to decrease the time on the ventilator 10 days versus 29 days for the no diaphragm pacing group. And so we were excited to be able to show that benefit there and in utilizing this technology. And so I concluded there, so that increase in spontaneous tidal volume will facilitate ventilator liberation. And again, you know, it's a long period of study there, almost 15 years. And so no doubt that we got better at critical care over that time. And so really we think it's good and beneficial, but we ought to try to work as a multi-center trial and figure out the role of diaphragm pacing in acute cervical spinal cord injury. So the final piece of data I was able to look at from our records is we had the hospital charges that the patients incurred. And so we thought, well, gosh, if I'm going to facilitate liberation from the ventilator by implanting early on, I must be able to decrease the hospital charges. And I think this is the key, that as we talk about this and people are interested in this technology for helping these patients, that's what people want to know. And that's what I was able to sell our administration on as I implemented this. As I said, hey, I want to do this. I think it'll get people off the ventilator, it'll get them out of the hospital, and we'll cut costs there. And so I went back and I looked at it, and this was the last paper that I published in the Trauma Surgery and Acute Care Open journal. And as we showed, the decrease in ventilator days facilitated liberation from the ventilator there. And the patients had significantly lower hospital charges. And this is this table will get I think will get the attention of the administration when you talk to them about implementing a pacing program at your hospital. And so, just like that, the statistics I referenced. So, just the hospital stay alone, almost $800,000 to get those patients with acute cervical spinal cord injury did not have a diaphragm pacing system implanted. And those that did, again, those patients, this was the 39, because the one patient died, just over $600,000 to get out of the hospital there. And so almost $150,000 savings by implanting these patients, facilitating liberation from the ventilator, and getting the patients out of the hospital. And so I think that's the key thing that the administration wants to hear about when you're talking about doing this program there. So I think looking at kind of about 10 years of experience with this, I think we can say it's the technology and the procedure is safe and feasible. We can improve the spontaneous tidal volume. We can facilitate some ventilator liberation, and we can certainly decrease the hospital charges there. And so that's how that's how I got started, and over 10 years now, we were able to show these differences. I would say in Jacksonville now, prior to my leaving, we had easily done 75 of these, if not approaching close to 100 of those. We would do about 10 to 15 a year. And that's been my experience there. And so I'm excited. So now that I'm getting settled here in Memphis, we're working with the institution to get the program up and running here, so that I can implant here and realize the same benefits at our trauma program here. So that's been my experience there. I know Ray's had a much longer experience, but not only with chronic, but with acute cervical spinal cord injury. So I think we have about 15 minutes or so left for questions, and I'll be glad to take any questions about the procedure or how I implemented the program in Jacksonville.
Excellent, and thanks so much for providing this talk. I know you were on call last night, so I appreciate you being awake this afternoon for that.
No worry.
It's an excellent experience that you've had. It's been a pleasure working with you over these number of years. I think obviously in our trauma hospital now, when I started at UH, we did not have a level 1 trauma, and we opened one, I think 4 years ago. So we're now like we do early implantations. We have at times even gone a little bit without tracheostomies on certain very select patients, because they still have secretion problems, but very select patients will consider weaning them without a tracheostomy. It's always difficult because of secretions. They don't have a good cough, as we all know. They've had other injuries that, sometimes the tracheostomy tube is still needed at times. I'm also like you, as we routinely put in feeding tubes in most of these patients at the same time.
Yeah, I had that same experience too, Ray, as we got better at this. And I really, as I showed in the study, it was about a 14-day time to implant. And the reason for that was, one, as I said, the restoration of physiologic derangement that was associated with the injury. Number two was, many of these patients need spinal fixation. And so coordinating of the care for stabilizing their neck. And then it does require access to the OR. It does require the surgeons that have the interest and the experience doing it. As I did more, I tried to train my partners there. And one in particular is really picked up on it. Brian Yorkitis is one of my former partners in Jacksonville, has really picked up on it. And so as he picked up on it and was able to do the procedure that was less dependence on my presence and availability in Jacksonville. And then I mentioned, as part of the technique, it does require the external programming of the generator, the external generator off the surgical field. Lynn Brandt, who's on here, Lynn helped me in probably 90% of these cases or more. Lynn is off the surgical field with the generator to test the implants, to mapping the diaphragm, testing the implants, and programming the generator. So it did require some coordination of schedules and operating room access. And that's part of why the average time was 14 days. As I did more and Brian was available, we really tried to, in some of them, get it done within the first week. And I did have a few patients, particularly a young, healthy patient prior to the injury, where we could implant before the tracheostomy was done, and we were able to facilitate liberation from the ventilator without tracheostomy. So that was good. The other aspect I didn't have in here, and that people have asked a lot, well, what happens after they're liberated from the ventilator and they go off to a rehab facility. So I was very lucky in Jacksonville. We worked with Brooks Rehabilitation Hospital, and there was a couple of the physiatrists there who took an interest in trauma patients and took an interest in this injury. And we worked with the rehab hospital to be able to transition the patients once they were off the ventilator to go to the rehab hospital with the pacing system in place. And then actually there was a physical therapist at who's part of Brooks Rehab and part of the University of Florida, and she had a keen interest in neuroplasticity, and so she took a keen interest in this and actually is studying it, looking at EMG tracings in these patients and showing improvement of the EMGs from the time of injury or from the time of implantation to the time of liberation from the ventilator, and then ultimately to discontinuation of the diaphragm pacing system. I didn't keep good data on this, but anecdotally, almost all of these patients were able to be not only liberated from the ventilator, but have their pacing system turned off and the wires, the external piece of the wires trimmed, and complete cessation of the need for diaphragm pacing any longer. And so I wish I had tracked that better for looking at those long-term outcomes, because I know people want to hear about those as well. But again, anecdotally, the vast majority of patients had the diaphragm pacing system discontinued and the wires removed. So Ray, I don't know if you have any long-term data on how many people you've removed the wires from.
Yeah, thanks. There's one other question from Lauren Frangella also. And on the chat, she asked about what is the impact on the ICU staff burden in implanting DPS in patients. And it's interesting. That's a great question. I think once you kind of get used to it, we all know complete spinal cord injured patients who truly are C2 complete, there's no respiratory drive. And literally, this is something, and it's interesting, and I've done this in many sites setting up, and a patient can't breathe, and you turn this on, and all of a sudden you see their abdomen moving, they're breathing some. So it's actually, you're just using this diaphragm pacing system as if the patient's breathing on their own. So you're using this to help wean them off the ventilator. And so it's, as we know, in any ICU, nobody likes new things. And obviously, and again, this is more of an orphan disease. You have, Andy's got a very active staff, and he's still only doing 10 to 15 a year. So it's a fairly rare, fortunately, disease process for spinal cord injury patients. And as kind of Andy had mentioned, that one of the benefits is the company Synapse Biomedical has technicians that go to help train the staff on how to utilize this device. So when we compare this to weaning to other methods that you had asked about, Lauren, I mean, this is where patients don't have a way to wean because we can't wean them as quickly in their standard way. If you don't have control of your diaphragm, you really can't wean off the ventilator well. I mean, some people may recover some, but many people are just using accessory muscles, and that leads to a lot of failures of weaning. So hopefully I kind of talked a little bit about this for you, Lauren, is that we can, it's kind of a new technique. Once you get used to it, in our hospital, we do a lot of these. And so it's almost like the nursing staff says, why don't you add diaphragm pacing to this patient who had a non-spinal cord injured who's been on a ventilator for 30 days. We now do that for other weaning things. That's a different talk with some of our newer technology. But again, it's a way to really help these patients by driving that ventilation. So once your ICU staff gets used to this, there's really not that big of a burden. I don't know if, Andy, you have other comments on the burden to your ICU staff.
Yeah, in the beginning, there's, as you said, new technology brings new questions, some anxieties about this. And I think the one thing that we talked about initially when we started doing this was, I think there was fear that if the pacer became disconnected or the battery died, which can happen, the device runs on now a C battery or a lithium battery, but in the beginning we were using only the lithium batteries. Well, it starts to beep obnoxiously at you to alert you to do that, to change the battery or to change the generator. There are 2 generators that come with each kit. And so you could just change the generator and resolve that until you change the battery. So we got everyone to understand, okay, if the battery, if you didn't catch it and the battery died, number one, the patient can still initiate a spontaneous breath, and many of the, almost all those had tracheostomies, so they can still initiate a spontaneous breath. Especially in the beginning, it's not very effective, but the patient won't have a respiratory arrest. And so I would say if the battery died, or if suddenly the pacing generator fell on the floor and shattered into pieces, well, you could just calmly, if needed, you could bag the patient because they have a tracheostomy, while someone got the other pacing generator and connected it to the patient, and they would not have an immediate respiratory arrest and subsequent cardiac arrest because the pacing device was not functional for that time. And so it took a while to get everyone to be comfortable with that idea, and it was just the continued use of it and people getting experience with it. It was the presence of, as I said, Lynn Brandt did the vast majority of these with me. So it was her in the ICU in the beginning, educating the staff, showing them, answering questions. The other thing that's really good about it is, unless she's on an airplane, she answers her phone and is available to me or to the respiratory therapist or the nurses. And so that really allayed a lot of fears. And then just over time, with the continued experience, people got used to it. And it was myself there checking on the patients, and every time we would come in the room, we'd explain to the nurses and the therapist that, hey, this is what's going on, and we would look at it, we'd talk about it. They were documenting that it was working, that the nursing staff of the hospital really embraced it. The leadership made areas in the flow charts for them, the nurses, to document about the pacer and it working. We implemented with this lithium batteries we were using, I think it was about 500-hour life of that battery. So the nursing administration said, well, let's not even get to that point of letting the battery die and then have to be in a panic. So they changed the batteries twice a month, on the 1st and the 15th, and to allay those fears. And so it's just over time, a group effort and part of the comprehensive care of acute cervical spinal cord injury patients. The other thing I would say about the nursing burden is patients to turn, get out of bed, have to have baths and those things. And so we did have in the beginning, as patients were being moved from a bed to a chair, as with many lines and devices, patients and staff get tangled up in and pull on them. And so initially the wires will pull out very easily until there's some tissue ingrowth and they get stuck in there. And so to avoid that, any of the wires getting tugged on, we said, listen, just if we're going to move the patient, let's shut off the pacing device. We'll disconnect it from the patient. We'll move the patient to the chair, and we'll once they get in the chair and they're settled, then we'll connect them back up and restart the pacing, so that we essentially eliminated the wires from getting tugged on and pulled. I showed you the two electrodes in each side of the diaphragm. There's also a small grounding wire, and that could easily be pulled from the subcutaneous tissue until there's some tissue ingrowth. And so that one in particular was pulled several times in the beginning, and we had to reimplant it at the bedside. So we set up, okay, well, we're going to move the patient. We'll shut it off, disconnect it, move the patient, and then reconnect it. And that worked well. The other thing we did was the little disposable over the neck telemetry packs that are used on the telemetry wards. The generator fit nicely into that, and so we would put the generator into that to kind of help remind everybody that it was there, and hopefully prevent it from getting knocked onto the floor or tugged on and pulling the wires. So as we did it, everyone got used to it, and everybody was excited for the technology and to see these patients improve. So.
Excellent. I saw, again, anybody can unmute and ask questions. Lauren has another question. She thanks everybody for that answers. Is that how early can you implant these things, and can you do it at the same time as spinal fixation? Well, I have done it at the same time as spinal fixation. I've kind of gone away from that. I think as we realize, people are doing spinal fixation very early, and I think in my experience, and I think Andy can talk, is that many spinal cord injured patients are, think once they fixate the spine, they're going to walk again, right? And so I think, and this is one aspect, is that, and I've said this to many spinal cord injured patients, well, after I get this spinal cord thing to get off the ventilator, will I be able to walk again? I go, no, this is just one aspect of your care. And so it is something that, and so I've kind of gone to not doing it as early. I think the patients have to realize that, they do have a catastrophic injury. And sometimes that spinal cord surgery that they have can have some other complications. So I've kind of, although I've done it, one big OR, spinal cord fixation, anterior, posterior, do the laparoscopy, put them in. We have with some of our newer technology now, if somebody happens to be having a laparotomy and have a spinal cord injury, we have our newer FDA emergency use electrodes that we could put in temporarily as we assess them. But I think I've kind of gone to, about day 5 or 7 of our acute injuries, and we're doing spinal cord fixation a little bit earlier now, day 2 or 3, depending on their injuries, that I've kind of waited a little bit to make sure the patients realize that, this is going to be one of their major problems. I don't know if, Andy, you've ever done it at the same time as spinal fixation?
I have not. The spine surgeons don't like to have things that prolong their cases or get in the way of them doing their cases. But I did. We were very lucky there with our spine surgeons. About 3/4 of the patients were, about 2/3 were done, had their spinal fixation within the first 48 hours after admission. About 75 to 80% had it within the first 72 hours. And so Brian Yorkaitis, my partner there, and I used to talk about, well, so we can get their spine fixed in the first 3 days, then why not try to get the pacing system, the trach and the peg done all within the first 7 days? And so people asked about screening and how we determine if there's a need. And so as soon as we admitted a patient with a cervical spinal cord injury, again, getting the physiologic derangement resolved. You can ask Lynn on here. I'm calling her, Lynn, hey, what are you doing on Friday? And she said, well, I'm available or not available. And I said, okay, well, what about Monday? And I said, okay, well, all right, we're gonna target Monday. We did have a few people that we targeted, we set up for surgery, and either they changed their mind and they wanted to withdraw life support, or their condition improved and they didn't need the implant. But we really were starting to try to get it done within the first week of following their injury. Get that physiology restored, get their spine stabilized, and then get the implant done. So that was my goal. It as I said in the beginning, it took a little bit longer. It was more like 2 weeks, but I was really striving to get it done within the first week. I think there was another question.
How many days after the injury is not useful after DPS? Interestingly, I've implanted patients up to 25 years after their spinal cord injury. I think my longest is 28 years. If you're a spinal cord injured and you have intact phrenic motor neurons and the nerves intact, even if you've not used that muscle for 28 years, we can recover. It'll take more time. And the longer you also have to rehabilitate the lung, because the lung's been on a mechanical ventilation for a while. And so mostly, as we all know, when you're on ventilators, you ventilate the anterior lobe, your posterior lobes get a little bit more fibrotic, and so we have to rehabilitating the lungs also. So it's it can be done years later. That's why, as Andy mentioned, my initial studies were on average 4 years post-injury. It just takes longer to wean off that. So it can take as long as, up to 28 years is my longest post-spinal cord injury that we implanted and got successfully off the ventilator.
Yeah, I had some in the beginning that as we were getting started, and it took us longer to get things set up and ready to do that. I think they had atrophied so much that we couldn't. The diaphragm was not able to be stimulated, and so they were not able to be implanted. That was the very first multi-center review we put together. About a quarter of the patients could not be stimulated. So, but once we started really doing them early, I don't think I ran into another patient that couldn't be stimulated.
Again, if you do have a complete nerve injury, complete transection, you can't stimulate the muscle. Obviously, there's a lot more work being done in nerve transfers, but really, if you don't have a nerve, you still need that intact nerve for this to work. That's why I think I presented at the Asia meeting this year, the spinal cord meeting, is that gunshot wounds to the neck, which have more of a blast injury. So our success rate is lower in those patients because there's such vascular trauma to the phrenic motor neurons. Hopefully that answered your question. Again, as people that have heard me talk before, is I can talk for like 10 straight hours on the diaphragm, but I know we kind of scheduled this for an hour, so I hate to keep people here. But if anybody wants to speak up and ask questions, go ahead. I know, Andy, when do you have to go back on duty in a couple hours for trauma tonight?
No, that's not tonight. Tomorrow morning, I'm going back to work. So I've got my rest from last night. It's a very, very busy place here. We're about twice as busy here in Memphis as I was in Jacksonville. We do get a fair amount of cervical spinal cord injured patients. So I think there's going to be a definite need here for the technology here. So hopefully we're going to get this through our IRB here soon. And get it up and running in the next, well, optimistic, I'll say a couple months, but hopefully in the fourth quarter of this year, we'll have it up and running and be able to start doing it here. Lynn was here a couple weeks ago, and we did a nice lunch and learn with the nursing staff and the respiratory therapists. And they were really, really, really excited to see the technology and hear some of the successes that we experienced when I was in Jacksonville. So
there was an article that just came out, and people talked about a little bit about when do you pick the right patient. And we used to, as I think you mentioned, always do phrenic nerve studies. So I wanted to at least get that out in our published literature. Is that we looked at phrenic nerve studies. You can have a false negative and a false positive phrenic nerve study that predict these patients. And that's why I really don't trust that anymore. Unfortunately, I was able to look at all my data of doing, because I used to always get phrenic nerve studies. And I think the diagnostic laparoscopy really can tell the difference between a complete denervation, which means it's nothing to stim, or just atrophy. And so that's the only way I can tell. And I really don't say a patient can't be weaned with diaphragm pacing until I look laparoscopically. And that's it's a diagnostic laparoscopy. It does involve surgery, but we're doing this on patients that are already on a ventilator. And so there's no such thing as risk-free surgery, but it's not something that is that difficult for these patients to tolerate, to take a look at their diaphragm to try to get them off the ventilator. So I think the benefits of being off the ventilator is significant. And though Andy had asked about, probably about 30 to 40% of all my patients do recover that breathing. The neuroplasticity that we all know in spinal cord injury is so important. The electrical stimulation helps in that, the afferent effect of electrostimulation. Most patients, or many patients, are incomplete. So if we can find any pathways from the cerebral cortex or the brainstem heading to the phrenic motor neurons, maybe a way for these patients to recover their own breathing on their own.
Yeah, Emily Fox is the physical therapist at UF and Brooks that I worked with in Jacksonville, and she took an interest in this, and she's written some stuff about it and got some grant funding for that. So if you want to search her name just to see some of this, Emily Fox, FOX. So there, she's likely to have some more stuff come out about the neuroplasticity piece of that. So
I saw one other question here from Dana Hughes talking about, right now this is approved. It's not a research device. The FDA has some old 1988 rules. This is approved because, as we know, spinal cord injured patients on a ventilator, high quadriplegics, is an orphan disease process. This is not a huge volume of patients. So it's approved under this humanitarian device exemption ruling that actually allowed it to be approved for. And the company Synapse is working on getting full FDA approval, which is through the IDE. And the FDA has been working with us on that. As we all know, the FDA has been very busy lately with our pandemic. We have a new temporary electrode that many of you may have heard about, that the FDA designated as a breakthrough technology for just weaning anybody off the ventilator. This type of technology can be used. That is actually authorized by the FDA for use on anybody without an IRB presently. But we hope in the next time period, in the next less than a year, we hope they'll have this category of FDA rulings that doesn't require an IRB. It's not research at all. It's just a way the FDA had of monitoring utilization of this technology going back to 1988. And the company is working on getting that so you don't need that IRB. It's still an orphan disease because, fortunately, as I like to say, there's only about 1,000 roughly spinal cord injured patients that will need this device long-term in the United States a year, which is a very small group of patients. There's over 105,000 tracheostomies done for failure to wean, which is a much bigger group of patients. That's why a lot of our other research is trying to get these other patients off that develop this atrophy that we kind of learning from our spinal cord injured patients. So again, in fairness to everybody that came on, is we kind of talked about this for an hour, and I think I saw that there's an email in the chat that if you have any questions, you can send it to Cody from Synapse. It'll reach out for us. I think my email is pretty easy to find, raymond.anders@uhhospitals.org. I'm always happy to answer any other questions. So again, if anybody wants to unmute, you're free to talk up right now. Or other than that, we'll kind of sign off here shortly. Andy, great job. It's great to see you. I hope you